And welcome again to episode 24 of the Race Academy program. The year is flying by. We've got so much on. It's all happening, and we are looking forward to hopefully a successful Australian dental exhibition this week. So feel free to come and visit us at booth 260, Thursday the 27th of October till Saturday the 29th of October. Starts at 10 a.m, runs through to 6 p.m, so there's no excuses not to be there after work. If you do need to work, but hopefully come along on a Saturday. There's a fantastic group of speakers this year. Hopefully I could talk you, some of you, into coming along to one of our lectures or one of my lectures on cosmetic veneers and streamlining the digital process. So booth 260, come and say hello. Anyone that comes up to me during ADX and mentions Professor Stubbs gets a free kangaroo. Looking forward to as many of you that come along. But I won't make haste. I will make haste and let you know that we have enormous amounts of registrations today. Good to see your numbers back in the game, guys. Again, apologies for the discrepancy we've had the last week or two with our last month with our technical difficulties, but welcome back. We've got Australia in, New Zealand, the UK, the US, and a bunch of countries across Asia. So welcome back to Race Academy program, episode 24. Dry mouth and what's the latest advice for your patients? A number of different reasons: dehydration, anxiety, nervousness, medication, snoring, breathing, exertion. And who better to talk us through what to do with you and your patients than Professor Stubbs? Over to you, Michael. I appreciate your time once again.
Oh, look, thank you. Thanks, Matt. And thank you, everybody, for watching. I'm just going to pull up my share screen. Xerostomia is it's actually one of the most challenging things to treat in oral medicine, other than burning mouth syndrome and, believe it or not, dry lips. All those three things very challenging. And one of the reasons is because, we understand that nothing beats the real saliva. So what we try to do is talk about understanding, firstly, I think, why does someone have dry mouth? And secondly, what can you recommend the patient to do? And I've got some things that you could suggest. And thirdly, I just want to run by a really interesting concept that I've been using more recently, which you might be keen to try yourself. So reviewing the anatomy first, folks, I realise we are talking to colleagues, but we understand that the major saliva glands, we've got the parotid, submandibular, sublinguals. But the interesting thing about a lot of patients with a dry mouth is utilising the minor saliva glands, which we have thousands of, can be a useful tool to actually moisturise the mouth. And I'll talk about that when I talk about pharmacology. So what's some ways that you can determine if a patient has dry mouth other than them telling you that? Well, one of the things is this very simple visual testing where we can look at the flow or the amount of saliva that you can see it can pools over the openings of the minor saliva glands in the lower lip. And it's actually very simple. It's unstimulated. And so literally the patient evokes their lower lip, as you can see in this image. And if you find that there's very little saliva generation over a 60-second period or longer, they have, by definition, a dry mouth. If you're seeing 30 to 60 seconds of unstimulated, free-flowing rates of saliva generation, that's actually normal. And if you actually have less than 30 seconds, so you involve the lip and you start to see all these drops starting to form at less than 30 seconds, you've actually got someone who generates a lot of saliva. Now, for those of you who might be interested, what is the opposite of xerostomia, dry mouth? It's called sialorrhea. Something that sounds similar? Well, sialorrhea, it means excess saliva. And sometimes that can be in relation to poisoning, but also it can be just a normal feature for certain individuals. They're the ones that will complain that they drool a lot when they talk and speak, and they've always got saliva and they're always swallowing. So I published a paper on this, on xerostomia management. It was about 15 years ago. I appreciate that's a long time. And I just thought what I'd love to do is, I was obviously a lot younger than Matt. But anyway, the thing is, I want to talk a little bit about some strategies that you could look at. And we talk about objective and subjective. So what's the difference? Well, objective is where we can measure saliva generation, stimulated whole saliva. And subjective is when someone tells you they've got a dry mouth, you look in their mouth and you think, well, actually, there's quite a bit of moisture in there. And those of you who may or may not be aware of this, this is a really good, simple test that I use. It looks complex. It's actually remarkably simple. That little tiny silver foil pack there is a little bit of boring, benign, almost like wax material. And the patient literally chews it for 5 minutes, dribbles the saliva into the cup, and then you can measure your flow rates. Now, we know by definition, and I put the reference down the bottom, if the patient generates 3.5 mils over 5 minutes or less, then they've got a dry mouth, 0.7 mil per minute. If those patients, they say, I've got a really dry mouth, and you do the stimulation test, and, we're talking a cupful, then firstly, yes, they're capable of making saliva, they can generate it, but B, start to think of other things. In other words, does the patient have what we call an oral dysesthesia? And a dysesthesia is where patients get these altered sensations, and even though we look in the mouth and we see it looks normal, so in other words, we can see saliva generation, there's no evidence of any tissue changes suggestive of disease or something stimulating or not stimulating saliva. But in fact, patients report dry mouth. There's a high association with depression. That's subjective xerostomia. But for most people, with the benefit of doing this test, I find it's actually quite reasonable, because you can get a marking in time of what their flow rates are. And that's actually very helpful when it comes to management of these people. And so, again, I've just put out the components. This is a buffering strip. So you literally draw up the saliva in the pipette. You use one of these to see if the pH, saliva is by definition alkaline. So pH 7.2, 7.4 is ideal. Obviously, it would come up as a green color. If you came up with a red color, pH of 4 or less, that's clearly not desirable, because we know that when you have a meal and you generate acid production from the metabolism of the bacterium plaque, that's what causes the dissolution of the enamel, the critical pH being 5.5, and you start to get reversal or loss of enamel out of the tooth rather than replacing it. So when you get a patient, let's say when you do the pH, where they're alkaline, generated saliva with the pH, that also when you're using this little buffer test and you drop the drops of saliva on it and you're getting a reasonable coloration on the bands, it means that we can't measure quality of saliva. We can only really interpret quantity, but it gives you an idea that what they make is reasonable. And I think that's also very useful when we start talking about dental management of our patients. So I suppose clearly, how would you know someone would have a dry mouth other than looking in the mouth? And one of them is people may talk about difficulties when they're speaking, sometimes swallowing difficulties, or when they're chewing food. They might say like they can only eat, for example, moist, soft foods, because as soon as they have something like a piece of bread or a cracker or a potato chip, bang, they lose all the moisture, they can't swallow it. And I think the other thing too is loss of taste. So, someone says to you, I don't know what's going on. I find that when I'm having a meal, I struggle to taste things. One of the things you might entertain the idea is, do they actually have dry mouth? Because you know that saliva is a medium, and when we chew we chew food in the saliva, it's the chemicals in the food that stimulate the taste receptors. Now, they're not just on the tongue, by the way, either. They're on the hard palate and the pharynx. But the point is, if you don't have saliva, we see this in radiotherapy patients. People have had head and neck radiotherapy. One of the things we always used to say to them prior to the treatment is, enjoy the beer and, dare I say, and enjoy your chocolate, because once you have the dry mouth, things never quite taste the same. And so the subtleties of taste can be lost. And of course, pain. I mean, what happens with moisture? It lubricates the tissue. So when you're chewing, often we see this in patients who brux, where they traumatize their tongue or cheeks, literally because the tissues are taut. They don't have the flexibility because of the lack of lubrication, and naturally enough, patients bite them, and so it gets quite sore. Intolerance to dentures. I mean, how many of you have a patient where they complain about their full upper and full lower dentures, particularly the full upper, not being retentive enough? And one of the things I realise is denture design, and I appreciate that, but also one of the things you might look at is the individual, and one of those things you might consider is dry mouth. Friendly tip that I've found useful in people that have dry mouth and let's say have a full upper denture, I always get them to put a smear of biotin moisturising gel or Oral 7 or Dentamed gel, some of the artificial salivas that exist in Australia, and there may be other brands internationally, and you put it under the fitting surface and then put it back on the roof of the mouth, and it actually helps create the suction. Do you remember at high school when you had the two glass slides with a bit of water between them and you could easily slide them over, but you can't separate them? Well, that's principle is what we would do when you use the gel under the full upper denture. So always consider that one, particularly if you have a patient who's reporting difficulty tolerating the denture and they've got a dry mouth. And dry and cracked lips. Remember I said in the beginning of this, one of the three things that are really hard to manage, dry and cracked lips. So my suggestion is, for those of you who get patients who have that issue, there's two elements you need to do. One of the things is patients who have dry lips, they tend to lick them intuitively. So they inoculate the skin, we call that the vermilion border, and with the bacteria in the mouth. It can be the yeast as well, Candida albicans being number one. But there's 7 different types of Candida for some of you that would know that. And the thing is, in that situation, Bactroban or mupirocin 2%, which is a ointment that you can prescribe. Dentists certainly in Australia can do that. And yet the patient treats their lip by smearing it on the lip 3 times a day for a good 5 days. It's an antimicrobial. So what's the difference between an antimicrobial and an antibacterial? Well, an antimicrobial doesn't just act on bacteria. It can knock off the yeast as well. And the usefulness is if you can keep the areas of the lips clean with regards to bacterial buildup or microbiology, using Vaseline is a fantastic emollient. There are different ones. In oral medicine, we're not that keen on lip balms or chapsticks. One of the reasons is they feel good when you put them on the lips, but what happens? You have to keep doing it, don't you? And it's because there's preservatives in them that tend to dry the skin slightly. So something like paraffin wax. There's one called Burt's Beeswax, which is very popular. Pawpaw is actually popular as well. I'm not a fan on that one. It's too wet in my opinion. But Vaseline, cheapest chips. For the ladies out there, cheapest lipstick in town. And it actually just puts it on the lip and it keeps it moist. And so here we've got someone, one of my patients actually poking their tongue out. Now, yeah, that's not a very interesting looking tongue, but it is actually interesting. And the reason is, look how atrophic, look how shiny and smooth that surface is. And you can actually see the dryness, can't you? So, you know, in someone like that with teeth, one thing you're thinking about is soft tissues. The second thing we're thinking about is what's going on with the dentition itself. Because what's one of the primary functions of saliva? It protects the teeth, helps reduce caries and periodontal disease as well, particularly maintaining good gum health. And, you know, like, have a look at that bite ring on the lower left aspect of this slide here. I mean, look at the interproximal caries. Now, they're really hard to manage. It's almost like you're chasing your tail. You know, you see a patient like this who has large numbers of root surface caries. Root surface caries is a good indicator, yes, of poor oral hygiene, but it's also a good indicator of someone with a dry mouth. And some of the great products that exist, materials like GIC, glass ionomers, that you can use to help mineralize the teeth and almost protect them without being too invasive restoratively. You know, you're always chasing the teeth because once you do the restoration, you start to get deterioration around the margins of the restorations, then you start to get staining, and it becomes to the point where you end up having to replace them often just because of those reasons. So this is a diabolical situation. So one of the elements, yes, is restorative, but the other element to consider in treating these patients is the biological. What can you do to recommend to help protect the work you're doing and also minimize the deterioration of the teeth? Fungal infection, again, I've highlighted this. There are 4 different types of clinical presentations of yeast. This is one of the most common, and we call this pseudo-membranous. In other words, white, like membrane that wipes off. And again, someone like this, one of the classics is patients will often describe that everything tastes like cardboard. Now, I've personally never obviously eaten or tasted cardboard, but I get what they're saying. There is nothing in the mouth other than an odd taste, and that's a classic symptom in someone who has oral candidosis, or commonly referred to as thrush. Again, as a dentist, what would you do? Well, you could advocate the use of fungalin, amphotericin B, 10 milligram lozenges, pretty straightforward, 3 times a day for a good week. I would suggest you put enough to give them for 2 weeks. Secondly, you could actually recommend oral miconazole. Now, Dactara and oral gel is a common brand that people can buy over the counter. Nilstat, nystatin, mycostatin, they're the ones also that are currently available. The reason I say it is because we can address the yeast buildup in the mouth to reduce difficulty in the tissues being uncomfortable and also trying to maintain oral health. Why is yeast buildup so important when it comes to people with dry mouths? Tick, 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 tick. It's because you have to think about aspirational pneumonia. Now, in places where patients are medically compromised severely, they may have high levels of the yeast, you're breathing it in. And aspirational pneumonia from oral yeast is a possibility. So again, the value of understanding how you can debride the mouth and maintain it as best you can with minimizing the infection of the yeast in conjunction with their dental health is really important. And as dentists, we have a great opportunity to do that. So what are the causes for dry mouth? Well, one of them is aplasia. Now, I put this in for the purposes of academia because I think it's fair to say most patients would have most of the major salivary glands, parotid, submandibular, sublingual. But, for every rule, there's exceptions, and some people have absence of one. One of the most important ones, actually, is the submandibular salivary gland. That is the one that generates what we call the resting saliva. So, when someone says to you, my mouth is wet, it's because it's the submandibular salivary gland generation that actually does it. When you put something in that's, say, acidic, the parotids go ballistic, and you've also got, of course, the sublinguals. And as you know from your training when we did dentistry, we know that the saliva has different constituents as well, doesn't it? I mean, parotids are very thin fluid, we call that serous, and then the submandibulars is mixed, and the sublingual is predominantly mucus. And the qualities that they generate of the saliva give the consistency that it has, as well as it's got mineral components in it and lots of antibacterial, anti-yeast, anti-cancer protective effects as well. And when we talk about Sjogren's syndrome, you may recall there's two types, primary and secondary. Secondary is by far the most common. So what's that? It means it's a patient who's got dry eyes, dry mouth, autoimmune induced, but they also have other autoimmune conditions. It might be rheumatoid arthritis, it could be a systemic lupus, it might be that they've got scleroderma. These are autoimmune conditions of which the process targets the major salivary glands, minor salivary glands, and also the tear glands as well. And it's interesting too that one of the most significant things about the primary form, so that means a patient who's got Sjogren's syndrome where it just involves the eyes and the mouth, is the risk of lymphoma. Now, the risk of lymphoma is much higher in someone with Sjogren's syndrome who only has the primary form compared to the secondary form. And so it's something as a dentist you can watch. One of the things we say to a patient is, let's say a patient has Sjogren's syndromes, and I see a lot of them. I always say to patients, one of the things you always check for is enlargement of the lymph glands. We call that lymphadenopathy in the neck, particularly someone who gets recurring swelling of the parotid glands in the face, and particularly having fever, night sweats. They're the things at night they're the things that we actually look at to suggest, is there likely to be a lymphoma happening? The eye symptoms are either involving either teardrops, replacements or substitutes. And so managing that is usually done through the world of an ophthalmologist. And that's something that you would recommend. Clinically, you could say to your patients, because we're not going to obviously check tear generation, most of us wouldn't, is you can say, do your eyes ever feel sandy or gritty? Because some people, again, go to the dentist, they just think it's about the teeth. They fail to understand that, you can actually ask questions about the eyes. And secondly, the oral symptoms, the fact that they've had dry mouth for at least 3 months. And certainly you'll find one of the things patients often do, and it's a question I always ask, do you often have to sip water or have a drink when you have a meal? Because they're the type of patients that does have dry mouth because they have to lubricate the mouth to swallow. So again, simple things, but really easy things to determine, does the patient have a dry mouth or not? And with the ocular part, again, a bit out of our scope of practice, but there's two main tests they do. One is what they call the Schirmer's test, which is where they put these little unusual looking little paper tags, literally, which they can measure the generation of the tears in that, and as it measures along the strip, they can determine the length of absorption relative to what is deemed to be a dry eye. So in other words, if over a 5-minute period of one of these on the eyelids on both eyes, and you're getting less than 5 millimeters uptake of moisture, you've got someone with a dry eye. And the positive vital dye staining, or the rose bengal, although not as reliable as the Schirmer's, it actually just shows the damage to the epithelial surface on the corneum. So this particular individual has dry eyes, and what do you notice? This incredible staining of the reddish color. And what that means is because the cornea, the eye surface, is dry, there's a lot of damage to the epithelial surface on the eyeball. Again, it's useful more for ophthalmology and rheumatology, but as dentists, you might ask the patient, have you ever had your eyes tested? Did you ever get that thing where they measure your eye tear flow called a Schirmer's test? Because the patient might be surprised and say, well, how do you know about them? Well, we know a lot about a lot of stuff. And, histologically, this is something that's a bit controversial, and I'll say it because we do minor saliva gland biopsies, which is where we literally, as you can see in the photograph down the bottom here, a small insertion is made, usually around the lower canine region, which has a very rich supply of minor salivary glands, and we blunt dissect out 5 of them. And then what we're looking for are these foci or collections of T cells that generate around the ducts of the minor salivary glands. So in other words, when you're looking at this type of slide down the microscope, by definition, we're looking at numbers of these, more than one of them in a minor salivary gland example, per 4 millimeters. And they work out a formula. And they say, well, let's say you've got 3 or 4 glands where there's a number of positive collections of these T cells, then the diagnosis is Sjogren's. Now, some colleagues use this as a technique to determine how effective the treatment for, let's say, Sjogren's syndrome is, or rheumatoid arthritis is, because when they're on immune suppressant drugs, you can do another biopsy and you can have a look to see if, in fact, there's improvement or still large numbers of these foci of cells. The reason I say it's a bit controversial is because academically that makes sense. I appreciate for a lot of colleagues that do biopsies in the lip, that makes sense. I suppose I look at it and say, well, if I did a biopsy on this patient, given that I've already determined they've got dry eyes, they've got certainly a dry mouth, I've done a simple test where I've actually done the saliva flow generation rate and looked at their lips, then something invasive, is it really of value? Because if you have Sjogren's syndrome only and you do not have rheumatoid arthritis or any other autoimmune condition, most rheumatologists wouldn't treat it. They would just say, look, that's it, something you've got to live with, which of course as dentists we know they don't have to. We can try to supplement what they're missing. And sometimes radiology is useful. This is what we call a silogram, and this is like a tree, a snowy tree. See, this is the submandibular saliva gland duct, which has been injected with dye, and you can see how it literally looks like a tree with virtually no leaves on it. And the reason that looks like that is because all the little glands that make the saliva have been destroyed by the autoimmune result. So certainly you can use non-invasive approaches to make the diagnosis. And of course you can do bloods too. Blood tests will demonstrate the positive antibodies and what we call SSA and SSB, or anti-Ro, anti-La. They're the kind of autoimmune antibodies that you look for in blood test. And the blood test, if you want to know what you request, it's called an ANA and an ENA, so extractable nuclear antigens, and also what we call anti-nuclear antigens. And we look at the measuring of those antibodies if they're present or absent to help build a diagnosis of Sjogren's syndrome. Now, again, why would we be interested in that? Because remember, if you've got a patient who's got Sjogren's, we may not be able to reverse the damage that's been done, but certainly if you've got a primary Sjogren's case, you have the responsibility, I feel, with the conjunction with the patient's physician, hopefully, that they would have advised the patient of the low risk of developing lymphoma. So this is an ultrasound. I don't pretend to interpret these at all. To me, it looks like the old-fashioned black and white TV with the snow, and so we always rely on the radiologist's input. And you can see here, this is the right parotid gland. It's been highlighted, and what it's showing is this mottled appearance which is interpreted as being destruction of the tissue and subsequently called Sjogren's syndrome, in conjunction with the other information such as the blood tests. And so finally, when you're making a diagnosis of Sjogren's syndrome, we can look at, out of the 6 criteria, you might consider the demonstration of dry eyes, symptoms of dry mouth, and objectively measuring lack of saliva generation, less than 3.5 mils per minute. And you can also, if you had to, you can do the bloods. That's usually, in my view, sufficient to make the diagnosis. Radiotherapy, this again, with the advent of new dental materials, has been a game changer. In the 90s, 80s, and previously, much harder to manage. And I'm not saying this is easy to manage now, but look at the caries. Look at the incisal tip caries. Classic in someone who actually has dry mouth. Usually we see it in radiotherapy. And also, as I showed you in the bite wing radiograph earlier, the amount of interproximal decay that can exist, which again can be dynamite to manage restoratively. And I think one of the most common conditions, certainly, or causes for dry mouth is medications. And we know that, look, 1 in 5 Australians are treated for depression, and about 1 in 2 are treated for anxiety. Nothing to be ashamed of. It's mental health, that's life. But a lot of patients that we treat can be on medications to help them. We talked about bruxism in previous talks, and so we understand that some of them can upregulate bruxism, but also some of the medications can upregulate the dryness and lack of saliva generation, which impacts people's teeth. And, you know, like, you may not necessarily have a patient who's on Seroquel or Mellaril, which is another drug for antipsychotic behaviour, but, you know, blood pressure tablets you might have. In fact, I'd go as far as to say you probably would have. And certainly, as I said earlier, a lot of patients may be on antidepressants, anti-anxiety medications, antihistamines, particularly hay fever time. A lot of people get dry mouth because it does tend to dry them up. And also, again, unlikely, maybe you get a patient on anti-Parkinson drugs, but again, it does happen, and you will get patients that can. These are more chemotherapy patients. They're clearly identified because you'd hope they would have put in their medical history that they're actually having chemo at the time. And again, chemotherapy really affects the generation of saliva, both minor saliva and major, but it also causes destruction of the mucosa, and we call that mucositis. And opioid consumption. You know, a lot of people on narcotics, whether it be what we might call for pleasure or prescribed, but the point is that considerably causes dry mouth and destruction of treatment of teeth and oral tissues. So here we go. We've got an interesting background, a little bit about why patients have dry mouth, how we can measure it in dentistry, and what do we do about it. Well, this is the next bit, and I think the best bit. And the first part, as I said earlier, is identifying the cause. The problem is, in many cases, you may not be able to stop the cause. So if you've got someone on a antihypertensive, a drug for blood pressure, or they might be on a tricyclic antidepressant like amitriptyline for pain management or depression or both, you know, I would not be telling the patient to say, look, you better stop that drug because there's a bit of damage happening on your teeth. You've got to work around that using what we know best, which is topical therapies, fluoride, tooth mousse, etc. But secondly, we also know that the benefit of these. Now, I like this particular toothpaste, the NutriFleur 5000. And the reason I do is I know a lot of us recommend the sodium lauryl sulfate SLS-free toothpaste like Biotine, Oral 7, Dentamed have something similar like a gel. But the benefit of this is even when you get those patients that have the dryness at night before bed, they can actually use it, brush their teeth, wait 2 minutes and then rinse their mouth out. It's giving them a topical fluoride. And the benefit of that, I think, is that unlike traditional methods, we used to make trays, like, you know, the bleaching trays, and we'd use neutral fluoride gels, is that compliance is not always that great. People are busy. You know, they're not going to put the trays in, wait 3 minutes, take them out, and then rinse their mouth out. But with the toothpaste approach, they're very likely to do it. So I find this one particularly useful. The fluoride neutral pH gels is really important. The old days, I used to use acidulated ones, no longer. And obviously a fluoride mouthwash daily or weekly could be useful as an adjunct, let's put it this way, in conjunction with using special toothpaste. And also see the patient regularly. You know how we normally see a patient 6 or 12 months? I would advocate 3 to 4 monthly if possible, because you are dealing with an environment here in the mouth where biologically, whatever you do to restore the teeth, whatever you do to maintain good periodontal gum health, is compromised because you already have the lack of saliva. And maintaining better oral hygiene reinforcement of that is important. This is a product many of you will be familiar with, Chlorofleur. It's got a small amount of chlorhexidine and, of course, the fluoride as well. And that's actually not a bad one to paint around the gums or gingival margins of the teeth. Again, I find that's quite useful. And for a lot of patients who have a dry mouth, we often look at it from the point of view of supplementation of moisture, antimicrobial activity, and plaque is a biofilm. Plaque is bacterial. So having some kind of antimicrobial approach as part of your treatment is actually, in my view anyway, quite useful. And this is just a case I did some time ago, but I just wanted to highlight, this is like a bleach tray, and the patient actually puts the neutral fluoride gel on the inside of the tray, and when they push it on their teeth, you'll notice it extends about 2 millimeters beyond the gingival margin, and it holds the gel on. Again, I have to say, we used to do this a lot more in the 90s, 2000s. I find a lot of patients' compliance is not that great. But then again, some people are very diligent and they do it. It's a useful tool to consider in your toolbox if you actually want to do something like that for your patient. And as I talked about a moment ago, the neutral fluoride mouth rinses can either be done once a week, or there are those that you can do, or the patient can do once a day. And we're all familiar with these products, I realise. Curacept I like. Again, antimicrobial approach, looking at the bacteria relevant to plaque, maintaining gum health as much as one can by reducing the burden of the oral flora, because when you have lack of saliva, you have loss of some of your innate protective mechanism that we have to control the oral flora in the mouth. Tooth mousse, great product, originally developed in Melbourne University by our previous head of school, Eric Reynolds, who was exceptional. And again, the supersaturation of calcium phosphate ions on the tooth with the tooth mousse is very useful. Interestingly enough, as a contradiction in terms, it works better if you're going to have a tray or something where the patient actually puts a bit of their saliva inside the tray and then puts the tooth mousse. It actually works much better on the teeth rather than just simply painting it on. But again, it's very useful. Some people use it to brush their teeth. Some patients we've found use it as a moisturising technique during the day. The problem, I think, with tooth mousse, like a lot of these great products, they're expensive. And so people use them minimally because they have to, because they can't afford to constantly buying these every day or every second day. And we also realise that, some basic things we can talk about, like with denture wearers, don't wear the dentures to bed at night. I know that's a very well-known, well-entrenched recommendation by dentists, but, it's amazing how many patients say, well, yeah, I know I'm not supposed to, but I will anyway. And the point is, it increases the microbial burden, increases the likelihood of oral candidosis, as we mentioned, and clean the dentures with a sodium hypochlorite and a brush. So what I recommend, if you think of it like a cup of tea with one sugar as a remedy, that's what I say to patients, 5 mils of nappy sand into 250 mils of warm water, and use that dilution, that's a 1 to 50, and use a toothbrush for the denture. Don't soak the denture. We don't want pink dentures going white, but what you do is you actually take the toothbrush, give it a really good scrub, and you're removing all the biofilm. In perhaps the 1980s, 90s, we used to think that the oral yeast organisms lived inside the denture as well as on the surface, but they actually don't. They actually exist mostly on the surface. So just having someone once or twice a week regularly using that kind of regimen debrides the oral build-up of organisms on the dentures, and it actually does help with tissue health and also reducing the amount of build-up of organisms in the mouth generally. And clearly avoiding foods that cause dehydration. Now, some of this isn't obvious, but some cultures are very specific about spicy food use. Alcohol, regrettably, is a dehydrant, so it means that if you have a patient that drinks a lot of alcohol, that will increase their likelihood of the dryness. And caffeine, again, a lot of us love our coffee or tea, particularly coffees. I think the Italians have got it right. They have a short black and they always have a little glass of water to replenish the water. I think that's reasonable. But again, there's simple things that you can recommend to your patients. And we've already talked a little bit earlier about the treatments for the oral candidosis. So mycostatin, fungal and lozenges. I've talked about Dactarin as one form of topical antifungal. If you're using a product like oral miconazole, Dactarin being one of the most common purchased over the counter by the patient, make sure the patient's not on warfarin, because if they are and they're using 5 mils, this comes with a teaspoon, 5 mils, which is the teaspoon in the mouth, they slop it around for about 1 to 2 minutes and swallow. So you're treating the oropharynx, in other words, the back of the throat as well as the mouth. If they're on warfarin, it can destabilize their blood thinning levels from the warfarin, the INR, international normalizing ratio, which is measured particularly with people that are on warfarin for valve replacements and things, that will really rise it up. So suddenly the patient will start saying, gee, I bruise much more easily than I used to. If I nick my finger, I bleed a lot more than I used to. So just be aware of that fact. And as I mentioned a moment ago, anxiety or depression, clearly we're not going to be there saying to the patient, now, this is what I want you to do for your depression, other than saying speak to their GP. And I think it's a very reasonable thing to suggest. A lot of patients are quite open about it. Some people aren't. We know that the nature of the work that we do, a lot of patients come to us with dry mouth because they're anxious about seeing us. I don't know why, but that is a common experience. And so obviously there's a difference between someone being anxious to see the dentist versus being anxious in general. But, you know, it's a kind of a good conversation to have. It's a very reasonable one to say, well, look, you know, for the sake of protecting your teeth and your mouth, you know, there are treatments that you can speak to your doctor about, and you might find that very helpful. Xylitol, I don't know how many of you out there have recommended this for your patients. You know, chewing gum is fine if a patient can chew and generate saliva. So that's where that saliva stimulation test is useful, because if you can demonstrate they can make saliva, it's about stimulating it. That's interesting. And so sugar-free chewy is great unless they've got TMD, temporomandibular disorder, which means it really aggravates it. They might consider a sugar-free lolly or something instead to stimulate generation. The xylitol is also very popular. The evidence is interesting about xylitol because it wasn't shown to be an absolutely great difference to those that didn't have xylitol. I think it's more the mechanical chewing of gum that stimulates saliva. We've talked a little bit already about artificial salivas. I've put the Bioteam products up, but there's Dentamed, great company in Melbourne that made a lot of artificial saliva products for Peter McCallum, and I particularly like their products, and I use them for my patients. There's Oral 7 out there. You can get it at Chemist Warehouse. Chemist Warehouse, I think, you have everything. And so, you know, really, it's what you're comfortable recommending for your patient. And the Xyli melts, I mean, how many of you have ever considered these? These are little tiny tablets where you attach them on the gingival region above the position of the sixes, which is roughly where the parotid duct enters the mouth, and overnight. And you can see here, which I think is interesting actually, because this is the publication, it was 2012, but it said that the perceived wetness was demonstrated to be increased and the perceived general comfort was greater. So again, it's something that is simple that you can recommend to your patient. And lastly, folks, this is something really interesting. Now, the Sally pen, probably about 7 years ago, 6-7 years ago, I did a study for a really great dental group. And what they did was they were trialing out the Saliwell, which is a stimulant. And so what it is, if you can imagine, you've got this in your hand, that blue button you turn on, and these little electrodes generate a very low stimulant current between the two. And when you place it under the tongue and you turn it on, it stimulates the gingiva around the 7-8 regions, which is roughly where the lingual nerve comes in and runs along the gingiva. And in that lingual nerve, we've got the nerves called the parasympathetics, which actually innervate saliva generation of submandibulars, sublinguals. So remember in the beginning of the talk when I said, you know, our resting saliva is often determined by the saliva flow associated with submandibulars. What this does is they place it under the tongue, turn it on, and it stimulates the generation of saliva. Again, it's an interesting one. It's not for everybody. And they are expensive. They're about $400 US. I get any patient that wants that from my point of view, I get them to buy it themselves online, but it exists. And it's not a bad suggestion, particularly those patients that say to you, listen, if you give me one more mouthwash or one more lubricant, I'll go he. So you can say, well, hey, try the Saliwell, the Sally pen. The other one is there's a drug you can use. I've tried it on a couple of patients, and I say it like I am appropriately. It's called pilocarpine. Been around for about 60 years. Pilocarpine, 5 milligrams, compounding chemists make it, where a patient takes one in the morning, and the benefit is it can generate a lot of saliva. It stimulates the saliva flow. The disadvantage is that patients can generally perspire profusely, and they may also get dilated pupils. So clearly it's not for everybody. And again, in oral medicine, part of what I love doing is not just talking about the mainstream, but considering some other things outside the mainstream. And so, there is research looking at stem cell regenerations of saliva glands, particular parotids. But, that's not, in my view, realistic at the moment. What we have at the moment is pretty much what I've already highlighted. So on that note, folks, and hopefully nobody's got a dry mouth while they've been watching this, I'm open for questions.
Well, thank you, Michael, again. How you turn all that knowledge into a simplified approach, we all appreciate. We are a little bit, we've got 5 or 6 minutes left, 5 minutes left now to go to questions. So I'm going to throw it straight out there. Firstly, where can we find a copy of your paper that you've written?
Australasian dentist.
Okay, and if anyone needs this information again, it's being recorded, so feel free to go to the Race Centre website and go back to the education facility to get back here. But thank you, Michael. We appreciate that. Is there any evidence to support dry mouth being hereditary?
No, other than the fact that they didn't actually have saliva glands to begin with, which is developmental, but no.
Okay, well, that's good for us family business owners there. And for dry mouth patients using CPAP, would a humidifying CPAP machine help?
Yeah, it's a good question. It's particularly useful if they've got, obviously, a full facial mask. If they've just got the nasal one, I know the idea is they don't breathe out through their mouth, but a full facial mask with a humidifier does help. I've had some patients tell me quite the opposite, actually, but for most people, logically, you think a humidifier, and most people do have a humidifier. ResMed, for example, have a new one where you don't need to put water in the machine. It uses, dare I say, your own secretions to actually create the moisture. But using a humidifier in a CPAP, perhaps full facial mask, is quite a reasonable thing. You know that all of us, our mouths dry at night. And so that's the reason why we advocate the most important time to brush your teeth, obviously, is the night time. And that's where, patients will often say with dry mouth, they wake up 3-4 times a night and they're having a glass of water because they're severely dry. Then, if they're snoring, mouth breathing, got a blocked nose, it really compounds the issue.
Okay, that's good to know. I just showing my my understanding and of the importance of rehydration, Michael. Could there be a correlation between dry mouth and restorative products like porous composites or PMMA?
Not that I'm aware of. I think, if anything, not dryness in the mouth, it would be more likely, if anything. One of the interesting things, of course, is the very remote possibility of skin reaction in the mouth, mucosal or lichenoid reactions and materials, but that's even rare too, but not for dryness, no. One of the issues, I think, is, because people that have a dry mouth still want a beautiful teeth and they want aesthetics. And as a dentist, one of the things I know that you'd be very focused on is if you're doing a beautiful set of 6 veneers, if there's any issues about dryness, or they're going to use a topical chlorhexidine, let's say like Chloroflor or the Curacet, which doesn't stain teeth, but you've got to be careful of staining the margins, and then the patient gets unhappy about aesthetics. So it's actually really tough. But I think it's so much better in 2022 than what it was in 1982 and what is available material-wise to restore the patient's teeth.
Oh, interesting, mate. And how long can Nutoflor 5000 ppm be used?
It can be used ongoing, because, at the end of the day, the way I view it anyway, is that if you're using it in someone who's got a high caries rate, whether it be through inadequate brushing or hygiene, or obviously dry mouth, or both, then its usefulness is actually, I think, quite strong. And I have to say that from a compliance point of view, they're more likely to stick out a toothpaste option than they are the trays. That's what I found. I mean, others watching this might have alternate views on that, but I find that you can use it every day if you had to. The issue too, I realise, is using sodium lauryl sulfates, the detergent in the toothpaste, the froth and bubble, actually dehydrates you more too. So it's a contradiction in terms. And what I usually suggest is Nutrifleur at night and a biotin type or Dentamed or Oral 7 equivalent in the morning. And that way you're not drying them out too much during the day.
Oh, wonderful, mate. And again, look, I appreciate it, Michael, your wealth of knowledge and the way you simplify it to benefit all of our clinicians across the world now. We'd like to say thank you. Interesting to hear that you haven't tried cardboard. I did like that. You obviously haven't had a steak cooked by my neighbour, but that's probably not a bad thing. But look, again, unfortunately, Michael won't be at ADX. It would have been great if he could have been, but he's a busy man. But come and visit us at ADX, booth 260. Feel free to come along anytime. Don't forget to mention Professor Stubbs for your free fluffy kangaroo. But again, Michael, is there anything you'd like to leave us with as per usual?
No, I just think, look, thanking Race actually, because, some laboratories that do education, it's all got to be about what they do. But, Race have given me a chance to share with you things that aren't things that the lab necessarily make, but they're sharing with you the knowledge and the opportunity to enhance your knowledge. And I reckon that's terrific. So well done, Matt.
Oh, look, thanks, Michael. We appreciate that. We do care as a lab, being a family business, the importance of looking after each and every one of our clinicians and, more importantly, their patients. But look, I thank you again. Feel free to join us next month. And hopefully, Michael, we could get you back again for another topic.
Will do.
No worries, mate. Well, thank you again. Thank you all for joining us. We look forward to seeing you for episode 25. Stay safe. We'll speak soon. Ciao, everyone.
Thank you. Bye.